Our next speaker is Emma Carrington from London, and it's a special pleasure for me to introduce her because I have been working with her for a long time, and she's going to tell us how this whole thing of the London classification will move our field forward.
Hello everyone, and allow me to start by saying what a pleasure it is to be here in this virtual space for Neurogastro 2021. Thank you also to the organisers for their hard work in putting this session together. For those of you that don't know me, my name is Emma Carrington, and I'm a clinical senior lecturer and consultant colorectal surgeon from Imperial College and Imperial College NHS Trust. Here are my relevant disclosures from over the last 5 years. I've been asked to talk today about the London classification and about what this adds to our literature. I will talk briefly about the role of anorectal function tests and when these are indicated, and then I will start to describe the rationale for why we began to develop the London classification. I will then talk about some of the key attributes of the protocol and what the classification schematic involves, and then I will give my opinion on exactly what the London classification adds, and also about what I feel the limitations of the classification are and some areas of hopeful future development. Disorders of defecation are very, very common, and they affect up to somewhere between 1 to 5% of the UK population. To illustrate this, the 2019 report published by the Bowel Interest Group found that up to 1 in 7 adults in the UK are affected by constipation. They also found that over 70,000 people were admitted to hospital with constipation in the 2017 to 2018 period, and that this resulted in over £162 million being spent by the NHS on treating patients with constipation symptoms alone. Now, when you reflect on this, it's really important to realise that this is just one disorder of defecation, and there are lots of other important tests of anorectal dysfunction, importantly fecal incontinence and functional anorectal pain, which this report doesn't cover. So knowing that there is a need for anorectal function testing and there's a patient population who would benefit from this, when are these tests indicated? Well, they're clearly not indicated in everyone. We know that the majority of patients will respond to lifestyle and dietary advice by their general practitioner, and that some will require upward escalation to bowel retraining or simple laxatives. The majority of others will benefit from a secondary care referral for pelvic floor physiotherapy or rectal irrigation. And anorectal function tests are only indicated in that subset of patients which require escalation of tertiary treatments to secretagogues or biofeedback, or even in those minority in whom we're considering surgery. At the moment in the United Kingdom, there are about 150 units which perform some form of anorectal function testing, and a number of different investigations are available at our disposal, both clinical and academic. But the most established of these investigations are anorectal manometry, the rectal sensory test, and a test of evacuation, commonly either the balloon expulsion test, defecation proctography, or MR defecography. Now, this is a really exciting time for lower GI function testing because over the last 10 to 15 years, there's been a real upshot of new technologies which are assisting us in really exquisitely characterizing anorectal function. And the most important of these is high resolution or high definition manometry. And this new technology has allowed us to use an increased number of sensors to exquisitely map pressure profiles within the anal canal and the anal rectum, and to display these in real time. And this is an enormous advance forward in our field. But with this has come a significant amount of variability. We know that the technology that we use significantly impacts how we interpret those results, not only from current studies, but also extrapolated from previous studies of manometry and also from the upper GI literature. We know that fidelity between different catheter types is different. So for example, we know that the pressure measured by water-diffused catheters is different in absolute terms to that which is measured by solid-state catheters. And we also know that the catheter width influences end results. In addition, there's a lot of data to support the fact that the protocol affects absolute values. And we know from the esophageal literature that that is the case as well, that if we measure resting pressure immediately after intubation, that resting pressure is going to be higher than if we leave the catheter in situ for a few minutes, allowing that pressure to return to a baseline value. There is even a body of literature which tells us that practitioner interaction affects the absolute values. So even if we can control exactly the protocol for the study, what the individual practitioner does affects the values too. So there's a lot of potential for variability, and that potential variability impacts our absolute values and how we use those results. So to find the impact of this, we performed a survey questionnaire about how individual centres are performing anorectal manometry. And we surveyed 109 centres from around the world to find exactly what their practices are and how similar they are to other centres. Firstly, we found that there was a wide variety of catheter types used performing different types of manometry. For example, with conventional, so there was about a 50-50 split between conventional manometry and high-resolution manometry at this time in 2017. And we found that there was variation between the use of solid-state catheters, seen here in these pie charts as green, and water-perfused catheters, seen here in blue. And you can see here that for conventional manometry, the majority of centres were using water-perfused technology, whereas for those who were performing high-resolution manometry, the majority of centres were performing solid-state manometry. So a significant variation there, making it difficult to compare results between centres. We also asked about manoeuvre description, so how those manoeuvres were being performed and therefore interpreted afterwards. And we found enormous variability in this. We found that squeeze, for example, had durations of between 5 to 40 seconds. And you can imagine that a squeeze which is held onto for 5 seconds is likely to have a different amplitude than a squeeze which is held onto for 40 seconds. In addition to this, and most interestingly, we asked individual centres about how they analyse these different manoeuvres and what analysis parameters they report in their studies. And we found a number of differences between centres in how they report their results. Some would report incremental squeezes, for example, some absolute squeezes, some squeeze duration. And so there was an enormous amount of variability there. Now, putting this all together, not only did the method of results analysis differ, but also the combinations of ways in which they reported these. And actually, between the 109 centres, we found 16 combinations of ways in which rest were reported, 18 combinations of ways in which short squeeze reported, and astonishingly, 43 different ways in which endurance squeeze was reported between these centres. And actually, the final conclusion from the study demonstrated that there were no two centres between the 109 centres surveyed which performed identical ways of performing and reporting the results of manometry. So there was wide variability and a great need for standardisation. And so this really provided the nidus, the catalyst, which made us want to form a group of like-minded individuals and work towards standardizing the testing protocol for anorectal function tests. And this was published as an open access document in Neurogastroenterology and Motility in 2019. And this really is the first international consensus published on anorectal manometry since 2002, but is actually the first ever combined consensus for tests of anorectal function. And this includes a description of test specifications, the minimum protocol, and the results classification, and the first ever results classification for tests of anorectal function. So now about the key aspects of what the London classification involves. I realise that I'm talking to an educational audience, and so I will not talk in specific detail about it, but I'd like just to illustrate some of the key important parts, just so that we can talk about what it adds to literature later on. The important thing about this protocol in the London classification is not just a protocol about manometry or one test. We know that anorectal function testing requires the use of complementary investigations because we know that disorders of anorectal function rarely impact one part of the anorectum on its own. So we know that a patient, for example, will likely have a number of different abnormalities of function. And we wanted the London classification to reflect this. So that in order for the London classification to be used, we have come to the consensus that assessment involves the use of 3 complementary investigations, that being high-resolution anorectal manometry, the rectal sensory test, and the balloon expulsion test, or an alternative test of evacuation. So this protocol does not involve just one test, it's a protocol involving 3 tests of anorectal function. Within the classification, we thought it was very important to suggest a standardized protocol. And in this standardized protocol, there are 6 key high-resolution manometry measures. That's rest, short squeeze, long squeeze, cough, push, and the rectal anal inhibitory reflex. Then the rectal sensory test and the rectal anal inhibitory reflex happening after the sensory test, just for practicality reasons. And after that, the balloon expulsion test. So there's a standardized protocol with these 3 different investigations, which all are incorporated together into a protocol which takes somewhere between 12 to 15 minutes. Now, there are a couple of interesting things about this. The first is a stabilization period in the protocol. So after intubation of the anorectum with the manometry catheter, there is a 3-minute period of stabilization before any recordings are taken. And then a second important thing to note is these important recovery intervals during the manometry test, so that each individual maneuver can be identified specifically and can be analysed in a post-hoc fashion. So here is what a manometry study would look like after completing the working group standardized protocol. So here's a high resolution trace with at the bottom of the screen, on the bottom left-hand corner, the beginning of the trace, towards the right-hand side of the screen, the end of the trace, and the exteriors at the bottom moving in towards the anal canal, which you can see as a band of green, and in towards the rectum, further towards the top of the screen, which shows the pressures within the rectum. And here you can see that after a period of stabilization, we can measure the rest. There are 3 short squeezes, each with a 30-second recovery interval between each squeeze, 1 long squeeze, 30 seconds, followed by a 60-second recovery interval, 2 individual coughs, 3 pushes, each of 15-second duration, and then the rectal anal inhibitory reflex, followed by the rectal sensory test, which you can see here on the study, but is obviously not measured manometrically. And what you can't see at the end is the balloon expulsion test. So not only have we described what tests should be used, but also a protocol of how to perform the maneuvers, but we also came to an agreement about how exactly we would recommend those measurements to be taken. And we recommended 13 key measurements for each of the maneuvers with a specific description of those measures. Now, it's quite important to recognize that most of these are quantitative measures, although some are qualitative only. And some of them measure pressure changes, some measure time, and others measure volume for the rectal sensory test. Now, once this protocol is performed, the classification then allows the clinician to plug in the results into the 4-part diagnostic algorithm of the London classification. And it's in 4 parts because our anal rectal function tests address different aspects of the functional anal rectal unit. And that is, so the 4 parts of the algorithm are the disorder of the rectal anal inhibitory reflex, disorders of anal tone and contractility, disorders of anorectal coordination, and disorders of rectal sensation. So each study using these 3 tests will come out with 4 different diagnoses, 4 different diagnoses of function. We then have plugged them into a classification which allows us to interpret those results and give clinical significance and the classification of the significance of findings. And this is where the London classification really moves forward, because this is the first time that this has been available in the literature. And you can see the classification documents here. I'm not going to go into too much detail about this because of the time that we have, but you can see that the pink boxes on the upper left-hand side describe the test and the maneuver that's required for interpretation. And then there is a diagnostic decision tree based on each maneuver, which allows you to come to a yellow box, which is a diagnosis, which we have categorized either as a major finding, a minor finding, or an inconclusive finding. Now, these three red boxes, these three classifications, give us an indication about how significant the consensus group thought that this diagnosis was, with a major finding being one that is generally seen in disease and not in health and is highly likely to be contributing to a patient's symptoms. A minor finding being that type of diagnosis which is found generally in patients with a symptom, however, can be sometimes seen in healthy volunteers, and so therefore is thought to be of minor significance. And an inconclusive finding is those that we see in some groups of patients with symptoms, but we also see in significant numbers of healthy volunteers, meaning that we're not sure about the significance of this finding, but it is something that's appreciated in the literature. So here are the first two parts of the classification. The left is the first part, the disorder of the rectoanal inhibitory reflex, in which we describe rectoanal areflexia being a major finding. The second part on the left is the second part of the London classification. That's the disorders of anal tone and contractility, in which we describe anal hypertension as a minor finding, combined anal hypotension and hypercontractility as a major finding, together with anal hypotension with normal contractility and anal normotension with hypocontractility. We then move on to the parts 3 and the parts 4 of the classification, with part 3 addressing disorders of rectal anal coordination, where we simplify the classification of dysynergia to describe expulsion, dysynergia, and propulsion, with expulsion describing the ability to either expel the balloon during the balloon expulsion test or during the test of evacuation, to describe propulsion as the rectal propulsive force during manometry, and dysynergia being a abnormal reflex contraction of the anal canal during a push. Then in part 4, we describe disorders of rectal sensation, with rectal hyposensitivity and hypersensitivity both being major findings. So what exactly does this London classification add? And I think this is a really important part of our discussions today as a group in this breakout session. Well, the first thing that the London classification adds is it adds a standardized protocol. This is the first time that we've had a standardized protocol for anorectal function tests as a group, and the first standardized protocol for manometry in over 20 years. This protocol, if it continues to be taken up, will reduce variability between institutions, will allow for easier post-hoc interpretation even within institutions with different clinicians, or will allow better interpretation of that study after it's been done by the same clinician, and will allow comparisons between centres, both in an academic and a clinical setting. It also defines terminology, and I think that this is absolutely key. For those of you who are interested in literature, it's always very confusing when you read research articles which use different terminology to describe anal resting pressure, for example, or squeeze, or increments, or the absolute squeeze. It's very confusing to have a number of different ways of measuring the same thing. And so the London classification actually gives a common language for us to be able to use as clinicians and academics so that we can each compare our results. It also, for the first time, gives a diagnostic classification. Up until this point, we've always described our anorectal function tests according to the test results, whereas now we're able to actually give a physiological diagnosis to patients' values. So a low resting pressure is not reported just as a low resting pressure, it's reported as anal hypotension. And so that is a physiological diagnosis. This also gives meaning to the findings and helps our clinicians to understand exactly what we're measuring. Now, this meaning is also given clinical significance. And this is important because actually in our field, there is a lot of variability between health and disease, and always a lot of debate about exactly what anal rectal function tests add to the clinician's ability to manage a patient. And so through consensus, we've been able to add significance, to add the clinical significance to those diagnoses, and appreciate that some of these diagnoses are interesting, however, might not necessarily be relevant. Anal hypertension, for example, is a finding, but it's a finding that we see commonly in healthy patients as well. And so to attribute significance to that might not always be in a patient's best interests. We have also, I should say, attempted to mirror complementary classifications in the way that we do this. And you'll see lots of similarities between how we have structured the London classification with the Chicago classification. I think really importantly, the other thing that the London classifications adds is that it really adds, it really has brought to our community a vehicle for training. Now we've got a classification which has been published and already in the last 18 months has been cited over 18 times. It's allowing us to benchmark our practice and to deliver training in a standardized way to clinicians around the world. And that in itself helps to catalyze research. It's been really great to be part of the working group because we've really developed this great collaborative network of interested individuals. And we hope that we can extend these practices to other investigations, bringing further clarity to our field, which have a lot of variability. That being said, I absolutely acknowledge the fact that there are a number of limitations of what we've managed to achieve in this first iteration of the London classification. I think the first thing that I'd hope to improve over the next few years is that of phenotyping. At the moment, each diagnosis only addresses one sort of area of physiology, but we know that patients often present with combinations or recognizable combinations of physiological features. For example, patients who have rectal prolapse, for example, often present with a rectal hypersensitivity, and they also often present with anal hypotension and hypocontractility as well. And so I hope that the London classification, as it goes through its next few iterations, will be able to start looking at these combinations of physiological features, something that we as clinicians all know exist, and start to put them together so that we can better understand physiological phenotyping of our patients with specific anorectal disorders. One thing that you will notice from the London classification is that we have all used very conventional metrics, and we haven't actually incorporated any novel metrics into the classification. And that's because when we were working on this, high resolution manometry was still in its infancy, and new metrics were only starting to come into the literature. I really hope that with time, we'll be able to develop these metrics further to be able to give a more insightful picture of the pressure profiles and the relationships in function between the anus and the rectum. And particularly our metrics for cough and squeeze are based on very little evidence in the literature. And I hope that we'll be able to improve that as time goes on. Also, you'll notice that a lot of the metrics that we've described are quantitative, and yet we know, particularly with high resolution manometry, that we see a lot of different pressure profile phenotypes using our new technology. We haven't included any qualitative color contour descriptors in the classification. There's no doubt that we see these patterns in our studies, and I hope that with further evidence we'll be able to use those colour contour plots more intuitively in iterations of the London classification to come. Description of normality is always an area of controversy in our field, not only because normality, it can be defined variably. Is normal dependent on age-matched comparators? Is normal about perfect continence? Is very difficult really to, even to decide where we all sit on exactly what we should consider as normal. But certainly at the moment, there's a lot of scope for us to be able to better describe normality. And with that, we'll be able to attribute more important significance to our tests, our test results in the future. I think there's definitely more work that needs to be done on the influence of hardware, particularly how catheter configuration and 3D devices are going to be incorporated into our in towards our practice in the future. We've got a lot of evidence to show that hardware does affect absolute values, but we need to have, as we're going to continue to use hardware from different manufacturers moving forward, we definitely need to characterize that more so that we can compare data between centers. And then finally, the clinical significance. I mean, we all appreciate that our classification is based on consensus discussion, not based on, clinical studies. And I think that further studies using new metrics are required, and further studies of the impact of our classification is definitely something which we need to focus on for the future. So to summarize, the London Classification is the first international consensus for combined tests of anorectal function. It provides a standardized protocol and classification of results for anorectal manometry, the rectal sensory test, and the balloon expulsion test. And I hope that it's paving the way for future innovation and development of a more precise description of the pathoetiology of symptoms of disordered defecation. Thank you very much for your time, everyone. It's been lovely to speak to you.